Once when oh,
Yeah,
trying to
I almost never do like Zoom stuff on the computer. It's always been on my phone, but sometimes, you know, sometimes the recording doesn't work quite as well on the phone, and you don't have as much control over the settings.
fair enough. No, I get it. I guess we're recording and I'm bad at editing, so we'll just start right with it because I
Yeah.
don't edit anything. I'll give a really quick background for people curious, and I'll give you like a 2 cents background. Um, I've had previous issues with my knee. Long story short, it's kind of random, erratic, and bizarre at times in regards to when the injury or when the pain comes up. I come from a background when I went to school. Initially, I'm athletic training certified, and it was very heavily musculoskeletal everything. Um, we didn't really appreciate the nuance and stuff, and that's sometimes fine for general population because general population typically deals with less nuance because you're not doing
Mhm.
nuanced things. You're not
Yep.
playing basketball or getting hit by people in football in the same volume and loading. And so naturally, the issues that come up in sporting activities can be slightly specific to the sport and the demands placed on the body. And the reason why I say that is because I've worked with numerous athletes who've had issues resolved from things, I'll say things with quotations, that most people would look at and say, there isn't science behind that. There isn't a randomized controlled study. There's a difference between a randomized controlled study because you need participants and identical issues and mechanistic hypotheses. So understand
Mhm.
anatomy, joint actions, how things occur, what could occur, and then when the musculoskeletal obviousness is ruled out, how do we then problem solve for what appears to be a unsolvable problem? And so I say that now because a lot of people, when I posted this initially, jumped on the do isometrics, do this,
Right.
do that train, which again, I have you as a wonderful resource. My cousin's a very well educated PT. She's awesome as well. And when I speak with you individuals, things become far more nuanced in regards to let's try and problem solve this versus the
Yeah.
class internet jump to conclusions interventionist. And the reason why I say that is because there are many athletes who don't know that.
Totally.
And that's unfortunate. And they'll continuously seek out information and they'll maybe fall in the trap of someone who's extremely woo woo because they say, well, look, it's hypothesis, it's mechanistic, and then I'm going to make up the next part of this. And they don't really tell you why they're doing something.
Yep.
And that's where one area goes. The other area becomes very diagnostic in terms of imaging, MRI. Let's try and find some sort of, I don't want to call it a pain point, but something we could intervene manually with. Uh,
Yep.
and then if that doesn't work, we'll result to exercise and then maybe some sort of rest and ice, and it kind of progresses down this wandering path of frustration. So
Yeah.
that's I wanted to clarify that because you are someone who works in a much more nuanced manner, and if anything gets glossed over that someone has confusion with, you could probably check out your chorus, which you are
Yeah.
out there, your knee chorus, and this is a shameless plug that I'll lead the charge on
I
because
appreciate that.
saw out yourself numerous times to help resolve mystery injuries, and so far none of them have come back. And so they've helped me a ton. And the moral of the story when it comes to injuries and working with a practitioner is if the end goal is to get better and you get better as the end goal, then the program works. Like
Yep. Exactly.
as
Exactly.
simple
That's the
as it
whole point.
sounds. And certain people react differently. I know acupuncturists who do great jobs with certain things. I know people who are very heavily in the traditional chiro manipulation area, people musculoskeletal, people massage. The point is, it needs to get you better.
Yep.
So, not every practitioner is going to have every solution, every answer. And that's not their fault because sometimes your injury is just a big, big mystery that requires either a different lens, a different angle, or maybe some randomness and luck in regards to picking the right thing. So just that's my
Totally.
one giant caveat. This whole conversation.
Yeah. No,
Or
completely. And I find that same thing because what they teach you in school is largely and this is for everyone, it's the randomized controlled trials. What does the science tell us? And that can work for, 90% of the population. People come in with really cut and dry things, and, it's easy to get them better with just okay, this is what the science says. We're just going to follow the protocols that are there because you fit squarely into this bucket. But then there are certain, just like you said, you can have a hypothesis based on what you know about the body that may or may not get you the result faster. And so, largely what kind of the science world is saying is the rehab exercises are just kind of natural history, and time heals you. And you're just kind of, hopefully hitting the mark with some of the exercises. But when you can do things that drastically reduce the time that you would expect this injury to heal with, or to heal in, then you know that you're actually having a significant change. And so for you, this is really important because we have a tournament next weekend. Mm-hmm. And it's not like, oh, okay, I have this thing, I can just rest for a couple of weeks and I'll be fine. Like, you weren't trying to compete. All right, that's fine. You can take a couple of weeks off. You can go easy on it, but this is something we have to continue to train through. And so that makes the nuance a lot more important. And that makes the finding out the mechanism, finding out the classification a lot more important. And so what I think, and this kind of leads into what people say on Instagram, is they just start to throw what works for 90% of people. I love doing ISOs for knee pain, but it works for a specific kind of knee pain. It's a lot of people. It's a lot of athletes. You're not going to, like, if you just hopped in and did some lunge ISOs, you're not going to injure yourself more, but that specific exercise is not going to, positively impact you just based on what you have. It won't do anything negative, but it's not going to do anything positive. Same thing. I saw a bunch of, knees over toes stuff. That one, probably nothing positive or negative. It's going to be just knee exercises. And
nice. It would be negative in some parts for a lot of things.
Totally.
Not just knees over toes, but isometrics. I want to get into that here because you're nice to people and saying that. I can see you're being nice. But
it's just like there's the shotgun approach where you're like, oh, this works for 90% of, or this is the only thing that I know that works, or this helped me specifically, so this has to help you, because all knee pain is the same, and all knee pain is very much not the same. It's a joint that people are honestly sounds scary and is scary if you don't understand it, but once you understand it, it's fairly straightforward.
Now, if I did isometrics before getting to this issue, and let's say I did have some joint issues within the knee that are capsular in nature, mm-hmm. Could that provoke irritation, assuming things aren't aligned or moving, or one thing might be tighter than another? Because I would imagine that there would be some contraindication if you're applying something that's not rotary functionally happy, and then a high compressive isometric force, which also has a rotary isometric component involved into it, because knee joint is rotational, despite what people mm-hmm. think. Yep. And so for me, if I think in my head, if I went and did that, I'd be like, good Lord, I think I'd be in agony tomorrow. Yeah. So I do think, while you've been nice and said some people might not hurt me, I think it can hurt people. I think people should hear that. Like, look, don't be silly either. Because recommending like that, I'm an athlete, I might just take that and set myself back 3 weeks and just constantly become swelling response.
And a big piece is like understanding guidelines of doing that. If you can do it in a range of motion that doesn't cause pain and inflammation, that's the big piece. Like, because specifically for the joint thing that we'll talk about that you have here, like, if you did a lunge hold in certain ranges of motion, wouldn't bother you at all. As you started to hit, certain ranges of knee flexion, that's where it would probably be a negative. So if you're going to do it, there's a safe range where it's not going to have any positive or negative, and then you'll get into a range of depth where it definitely will, cause some inflammation and probably set you back a little bit. So there's good ways to do it. There's bad ways to do it. And again, everyone is individual. So you can say, all right, try this. But the more, like, anyone that does my knee program, they likely already have a diagnosis, or I talk to them, they give me their history, I'll ask them a bunch of questions, and then I will put them in the specific program that works for them versus, oh yeah, here's, 3 general exercises for knee pain. It's like, no, I have 6 or 7 different protocols that will put you through based on what your presentation is. And then even further, we'll make adaptations, within that protocol based on what you find. And so what you have would probably fall within my meniscus category, just because people understand that. If I told you on the phone, we would classify it as like a knee derangement. People don't know what that is. So, but they do understand meniscus. So we kind of have that, but then we would make things more specific for you in the middle of your program.
So what I would love to do, if it's okay with you, I'd like to walk through the intake essentially that you did with me, because we had a phone call earlier about this where I did an intake with you.
Yep.
And I originally wanted to kind of film that, but I know you're really busy and you helped me out on a short notice, because I think that would be something I think your course talks about. I'm assuming how you do intakes. I have not taken the course, but I've lived firsthand the experience of you helping me. And then so people can see what that's like. So let's just pretend like I called you. You gave me a ring. You said, "Hey, Max, your knee hurts."
Yep.
Take the lead, and I'll follow suit as if this conversation hadn't occurred, and then we can talk about some things maybe to work on.
Yeah. So, and this is like a normal history that I would just do with a patient that comes in the office. We're just, doing it over the phone, and then we kind of would get into the hands-on stuff later. But so I guess first thing is, tell me, we talked about kind of how this happened. You're doing some lateral agility stuff. It feels sort of on the outside of your knee, almost fibular head. And can you tell me like what ranges of motion or what movements tend to provoke it?
So this happened 10 days ago, maybe 7 days ago, September 23rd-ish. There was some irritation leading up to the day that it occurred. But I mean, irritation's a relative term. Like sometimes your knees just hurt. And so you're not really thinking much of it. It wasn't anything sharp, wasn't anything acute, wasn't anything that apparently was chronic. It was just kind of like, oh, I felt something, but you feel stuff 95% of the time anyway. Went and played that morning, felt okay. Then that afternoon, just like this random shooting knee pain. Non-specific in terms of I couldn't evoke it doing the same thing. Lateral stepping seemed to really bother, like a cross. If I did like not a crossover, but a cross step, a karaoke in an upright position kind of bothered it. Anything more upright seemed to bother it. Like I could play defense in a bent position and shuffle around and didn't have anything, but like I'd land. And this really affected how I ran. And so this enters into a weird realm of like, am I now hurting myself because I was running goofy after type world? Because I'd get like these super sharp step on attack pains in the knee joints. And it doesn't feel tendonitis. You don't go like, oh, put some manual resistance on it. And the next thing you know, scalar pain based on intensity. It wasn't like every time I bent my knee, it hurt. It was super random. It felt really grabby with the term I'd be using, or catching, but not sticking like a meniscus where it's like your knee actually locks.
Yeah. And was it front of the knee, side of the knee, inside the knee?
Definitely anterior, so front of the knee, but posterior to the tendon. So it felt inside but anterior, and mildly lateral. More lateral than medial, put it that way. I didn't feel anything immediately. I would get afterwards, I have gotten, and in the past, I have gotten very bad lateral tightness on my right side.
Yeah.
To the point where one of the most alleviating stretches would be putting my leg up in a hamstring stretch, like on a table. I take a band or a rope and I wrap it around my foot. So I cause some sort of inversion. Yep. So stretching the perineals as I rotate my body to that side. So going into like my shoulder coming to the top.
So internal rotation of the hip plus inversion of the foot. Okay, so right there, that's all I need to know essentially to move in the direction of what the treatment is. We could go into, you told me no previous surgeries on this knee.
No surgeries, a possible injury like 3 years ago. I did have something very similar in nature to this, which is why I called you. that occurred 4 years ago and put me out for like 6 months.
Yeah.
And it wasn't like anything that got worse or better. It just wouldn't go away. It was very
Yep.
bizarre. And that's why it was like, oh, is this a loose meniscus? Is this like walking would hurt randomly? Just I jump out of the gym. I changing the gas pedal to my brake
Yep.
would drive me nuts. To get out of a car would be painful. But then all of a sudden I'd have no pain. And it would
Yep.
just be super random, super erratic. I basically gave up all deep squatting because of it. It was like, I'm not doing that anymore. That seemed to be most irritating of all things.
Right.
And then like I messed around a whole bunch with lockout stuff. And is it something rotary where it's like that end range of motion? You have the last 30 degrees, you have the tibia and femoral heads
Yep.
rotating on each other, whether it's closed or open chain, femur versus tibia. So I have my own nerdy process going through this.
Totally.
Nothing seemed to work. Like some of that helped. I met my cousin. She was like, maybe it's fibular head sticking and some other things associated with it. And then eventually some of these stretches helped me get better. But again, I just took an absolute, not even a shotgun, like a flamethrower approach to this thing.
Yep. Took
And
everything possible at it.
everything at it, because I was at the point where it's this or surgery. I'm like, I don't know what is going off my knee.
Yep.
It became a point where it was hurt my business because I couldn't even like demonstrate things to my athletes.
Totally.
Like I need this to go away.
Yep.
And so that's where I'm at now. Is like I felt something very similar, something very erratic, something catchy. One day it's above my kneecap, one day it's below, one day it feels hamstring, one day it feels calf.
Yep.
All the insertion origin sites. So by the way, if you're an athlete listening to this, you're not a nerd like me, you can easily just go on a type in knee anatomy, muscle origin insertion, and you can look at stuff. So when you talk to your provider, you can mention these things like, hey, what about this? What about that?
Yep.
Oh, I moved my calf. I didn't realize my calf goes behind my knee. So just having a little background can be helpful for you want to talk to.
Exactly. And even the little bit that you're able to give, you don't have to be an expert, but even the little bit that you give, if you don't know any anatomy, any little bit that you Google definitely helps point in the right direction. And so kind of breaking this down, 3 things that we have to look at. The first one we'll talk about is the mental side of things. You're going to hyper analyze things just because of your personality and your knowledge base. And so we have to understand that, all right, you're going to be more aware of really subtle changes, but you also have the capacity to amplify things in your mind because you are so aware of them. It's like, it's like doing a bicep curl. You can feel your bicep, but then as soon as you make your body more acutely aware, you have way more sensation in your bicep. And so your brain can start to do that. The more you know, the more you start to visualize, the more you start to think about it. So half of what we have to do is say, hey, I understand what's going on here. This is the mechanism that we have, and this is how we're going to treat it. And then you can start to conceptualize that for yourself, and it calms down the mentals quite a bit. So that's like working with any athletes. You kind of have to see where they're at, like how much concern do they have over this? First of all, how much are they going to overthink? How much are they going to underthink? And you kind of have to, talk to them and understand where they're at mentally. And so for you, just knowing that you're going to think through all of this and you're going to be hyper focused on, any pluses or minuses, you're going to give details to the nth degree. We have to, combat any focus that's too much and that's unhelpful at that point. But I think we're going to be able to combat that pretty easily. I don't think you're like catastrophizing about this. That would be the concern, is that, and I don't think you're at that point. And I don't think you're anywhere close to that. The next 2 things, so we have that, just the whole mental side of the athlete that we have to take into account. The other piece is, how do we classify this? So we don't need a technical structural diagnosis in order to move things in the right direction. So we go, all right, is this a joint derangement or is this a dysfunction? The easiest way, and if you're really into sort of the McKenzie method, people will criticize how I'm about to explain this, but this is the simplest way that I know how. Is this a soft tissue or is this a joint thing? And if this is what's called a dysfunction, more the soft tissue side, you're going to have very predictable pain. It's going to be likely at end range and loaded. And so yours doesn't fit into that at all. It's not really end range, it's sort of mid range. It's loaded or not loaded. There's not really a ton of, consistency there. And it's very unpredictable. So it doesn't really fit that category. That one also typically happens when it's been more than 8 weeks. So there's zero things that point us in that direction. But what we do have is a joint derangement, and that would be kind of sporadic in what causes the pain. There might be certain ranges of motion that always do it, but it's not necessarily end range. And then shorter than 8 weeks ago. And so that puts us in the derangement category. And so what we start to do is we say, all right, we want to find what motions are going to be alleviating for this pain. We have to, 99% of the time, it's going to be passive knee extension. We have to find the alleviating motion. And then we just go progressive overload with that alleviating motion. Starts passive, and then we go active, and then we go active resisted, and then we go closed chain, open chain. We can progress all through the rehab just with a progressive overload, but we have to find what that motion is first, and then we move forward as fast as we need to. And so we're kind of at the point now where I'm pretty sure it's going to be extension, and then we just have to find, is it dead center, is it internal rotation, is it external rotation, then how much fibular head motion do we need to restore there?
Okay. No, makes total sense. I will add, like, there does seem to be some level of swelling. I don't know today, but I know repeated efforts, definitely the second time in the day is worse. The morning it clears up. There's no morning pain. It's typically like the inverse of an itis, where it gets actually worse later in the day.
Yeah.
There does seem to be some, like, long sitting causes tightness to it. And then, like, there does feel to be some co-contractive aspect of it, where it's like if the hamstring contracts aggressively. So, like, I can go into a lunge iso and just randomly in the middle of it, I'll feel the hamstring like grip and will pull whatever the heck that is in there and lighten me up like a Christmas tree, like 10 out of 10 pain. Now we'll relax and go away, all in the same set. So it's not like this, like, stable reproduction. It's very, very random. Like, I'll walk downstairs in like the 4th sterile herp, but the 6th one won't at all. Same thing with playing the basketball was tough because you can make a move and out crossover's fine, but then, like, jogging back on defense, one random step, you've stepped on a landmine.
And that's the whole thing, is can we get a joint motion that just calms down and calms down and calms down to the point where you no longer have those random things that pop up. And so let's get into like a little bit of the physical eval and treatment. You sent me the picture this morning of the one motion that could pretty much replicate this with that sort of, did it?
It went away after like 4 reps, but that was the one that I tried, did it, and I was like, oh, maybe that's it. So I got the video out and I took the camera and placed it, and like that's probably the closest I can get to that.
Okay. So what we want to do is we want to find something that will generally reproduce it. So if you're, if it is a side shuffle, then we'll do that. The goal would be as much predictability as we can with what is going to reproduce it. We need to try that. Just to get a baseline.
So it's so random. Like, jogging can absolutely, like, light it up. Just a basic trot. And then, like, if I'm in like doing ball handling, like stationary, like a wide stance and just rocking side
and forth a little,
will really, anytime I shift laterally, it will really bother it.
Like, so the process now will be, all right, let's go out and unfortunately, this is something that we have to provoke once so that we can say, all right, are we getting, so you don't have to do it right now, but
I got the lights are on. We have a weight room.
Do you? Perfect. Do you have a basketball in there?
Of course.
Perfect. Let's go. Let's do a little bit of the ball handling just because it's stationary.
I won't bounce it for the sake of noise. I'll just
Perfect.
do the pistol Pete between the legs hand. I think it's
Perfect. A little bit of that. You might have to turn the that blur off.
yeah, I got step. I think it'll catch
Just step away.
So I'm totally. I thought maybe it would
Oh, there you
focus a little bit focused, but we'll do full focus. Hang in there, everybody. We are going to figure this out more. I think it's settings,
Yep.
background,
It'll be under like the video. Yeah.
no blur.
Blur. Perfect.
Okay. Cool. Is that better?
Yep. Perfect. So we're gonna do just that side to side.
So like I'll dribble it. Let's do that way. So like
That's not making any noise. I can barely hear that.
the rocky motion
Yep.
typically gets it. Like I said, it's a lot better today. I haven't really
Good.
pushed at all, so I don't know.
Yep.
That feels pretty good.
Good.
I'm trying to do everything I can.
Yep. No, I mean, if it's not provoking it, then that means because you did some of the exercises last night, so we're starting to move in the right direction. It seems to me that as you like drive into either internal or external rotation of the hip, that tends to be a big determining factor. So
Like something like this position, where if I can pull my legs, you can see like rotation,
Yep.
and like anything where that femur would rotate on top of the knee joint.
Yep.
Like if I held an ISO, like that kind of got it right there. It's a little bit anterior today.
Yeah.
I don't know if
Which is good.
Because I don't know if I had stretched my quad yesterday, and I haven't stretched my quad in 4 years, and created some like cute because I pulled it a lot further than I probably should have.
So what we do from there is like, all right, we can maybe reproduce it a little bit with that lunge. What we're going to do is this passive knee extension. We're going to try a couple different angles. And I know you're doing this. My guess for you is internal rotation of the knee. So you can see, just for everyone at home, this is external rotation of the hip. This is internal rotation of the hip. And what we're going to do is a passive extension. So I'm just going to press down on top of the quad with a little bit of that internal rotation. And that's a joint glide. So you'll probably feel a little bit of a stretch, a little bit of pressure in that fibular head area. And we're just going to do like a set of 20 to 30. And then we go and retest that aggravating movement. And we see, can we replicate it? What we're looking for is either decreased pain overall, or so decreased pain overall, or we're looking for what's called a centralization. So you notice that you're feeling it more in the center of the knee today. That's a positive.
Okay.
Either complete elimination or like a centralization or localization of the pain. If it becomes way more pinpoint, that's what we're looking for.
All right. So
we do a set of those guys.
I was listening to you. Couldn't see it. So now I'll do like a skip.
Yep.
I haven't done any like.
And if this is feeling good, then that's a positive.
Pretty good. Like at here, like near end, at that position there, I'll feel it a little bit. I do have like, I historically don't stretch at all because I have things that I'm kind of, if you've ever seen like Mr. Burns, if you're a Simpsons fan, go to the hospital, he had like every disease, but they're all each other. So if he's basically immune to everything because everything's fighting each other off. Kind of how my body feels at times. And so like I'll get anterior knee pain, but then I sat there and thought about it, not anterior, but like proximal, top of the kneecap.
Yeah.
It was like, is that because I left it in excessive extension while I'm sitting there on a foam roller attempting to get like maybe a meniscus to glide back in place?
Yeah.
Which
I'm okay with. I'm okay with like feeling it in a different spot. If we do something and all of a sudden the pain changes, that means we've manipulated it and we're moving in the right direction. So now let's do another set.
like Wednesday when I
That
played,
internal rotation and an
Yeah.
extension there.
I played what's it? Today's Thursday. I played Tuesday, and like it was gripping the top of the knee.
Yep.
Next day, like really bad to the point where I did like a jump stop and I was like, oh my God. And then I only played because we were still on the court just trotting around, but that was just pretty stupid of me. And the next day I went to shoot around and it had all moved anteriorly to the
Yep.
joint, but I don't know if that was swelling based because whatever was gripping, like it felt no bueno.
Yep.
And I don't know if that could like you have some sort of joint dysfunction that you're trying to fight through. And if you're going to have something grind or irritate in a way, I'm sure that causes some sort of inflammation response.
100%. And specifically with these joint derangements that we described, you can absolutely have swelling like that. It makes a ton of sense. Can we try that skip again?
Like squatting like deep, like getting off a chair was bothersome for a while.
Yeah.
Not as much now. I don't, but that's historically like I don't squat anything deep. So like because of this issue in the past.
Yep.
So, like that feels fine getting up as long as I'm
Good.
not, especially if I don't baby it. Sometimes if you're overly cognizant of it, you hurt it more.
Totally.
You're weird.
Exactly. You're just so focused on it. Let's try the skip again. And then if it's feeling good, then we progress. We progress the load.
I'm gonna jog. That'd be a
Great.
good one for me.
That sounds good.
I have enough yardage. I think I got 30 yards down here. So
Oh, nice. Got everything you need down there.
yeah, who knew?
Feeling all right?
That feels fine.
Great.
And one of the things is too, like, if you're a nutso athlete like me, like your first jog always hurts.
Yeah, exactly. So if that feels good, then we're
I'm
moving in the right direction.
gonna go down now one more time.
Great. And then I'll get set up for the next progression.
That kind of bothered me right there. That push off.
That push off did?
Yeah, when I have like a forward lean into a push off.
So let's try this now. We're going to do a TKE. So this is a more loaded progression. We're going to go and watch my right leg here. We're going to go internal rotation. So I keep my hips squared. And all we're going to do is that TKE. So slight bend in the knee and then extend it, but hips stay square. So there's a little bit of rotation.
I feel some lateral tightness then here, like some
tightness I'm okay with. I don't want that same pain. So if it feels tight, like for me doing it right now, that felt tight and I don't have any knee issues. And so it should feel slightly restricted.
I mean, it's very low grade pain, but I would call it a pain scale.
All right, let's do a handful of reps and see if that diminishes.
So a little bit right there.
Yeah, try to keep your hips squared the whole time, and then just knee. That is all right. It's the only range of motion that I have a lot of is hip internal range of motion.
So is that rotation, like right last point, rotating out?
That last bit, that's where you feel it?
Yeah, like it really wants to like, I almost feel like I need a pop kind of thing. Like,
yep. Let's try external rotation of the hip and do the same thing. But keep your hips squared even more. Yep. So you should feel like a tiny bit of stretch as you're doing it. Yep. Any issue with this?
Well, that was fine. It's that rotation where like here.
Yep. So the one small tweak that I'll make for you is, and I'll zoom in a little bit. You're coming here and you're like rotating into it. I want hips to stay square and you're just sending the knee back. So I'm not trying to create any torque. I'm trying to pre-torque. So I have pretty good hip internal. So I'm going to exaggerate it. I'm trying to pre-torque and then just send the knee back. So I'm not from the side. It just looks like this. I'm not rotating at all in my hips to get there, if that makes sense. But my knees are in, and then I'm just sending that straight back. Does that feel any different pain-wise?
There's no pain there.
Good.
I have no range of motion though. It's like
totally fine. Let's stick with that.
That's as far as it goes.
Let's stick with that. And then we're going to check that jog again. Yeah, that's exactly what we're looking for. Feel how you're not like swooping, you're just sending that knee into extension now.
I kind of moved a little bit of the weight off this leg.
Yep. No pain with that?
No.
Good. Now let's try that jog again.
It's gonna be hard to reproduce it, but I mean, even just jog. Yeah. I'm trying to. Range where it's like here.
And again, it is so random that it's going to be hard to reproduce.
Yeah, I don't feel it. But like yesterday, I had to kill my shooting workout because I couldn't even jog.
Got it. So we have improvement from yesterday, just kind of letting it relax. So that's where I'd start with you. And then at a certain point, you can get to a band with that same TKE. So the passive one, we probably need a little bit more loading, especially if we want to be aggressive with it. But then it becomes just, band pulling, and you're just doing a TKE with a slight bit of hip internal rotation. You're not trying to torque the knee. You're letting the knee stay, fixed where it is and not swiveling the hips. You're just letting that pre-tension be what causes the that knee torque.
Side note, doing something like this doesn't bother at all.
Yep.
I've been on a hip machine, but it's the same push-off position.
Mm-hmm.
Right, so it's like that where that foot drops and rotates.
Yeah.
But that doesn't cause any issues when I'm not grounded, right?
Yeah.
When it's that toe is rotating.
Yep.
For what it's worth for you too, when I did hurt it, might have been stupid and squatted that day really heavy afterwards because I thought like
that's zero torque on the knees.
I thought it was a tendon maybe issue, right? So I was like, oh, I'll just do some heavy eccentrics.
Mm-hmm.
Not a wise decision, I don't think. So I haven't squatted or anything. But with that being said, the squat pattern without any depth doesn't seem to irritate me.
Yep.
Like with more depth, well, like if I'm here, let's just say I'm here. Like these patterns don't bother me.
Which I wouldn't expect to, because your femur isn't rotating as much in that higher range.
Walking down my driveway, I feel maybe that's the toe off part where it's like rolling in.
Totally. Yep. But with the stationary foot, if you're not hitting the depth, there's probably not enough femur rotation. But then as you're going through the gait pattern, there's going to be more change in that knee rotation.
Gotcha. Now, just throwing all the information I have at you in the world here.
Yeah.
One of the things I did was the day before I heard it, maybe I irritated it, is I took kettlebell banded swings, but like I had a weird setup where I was forced to really like drive my knees out the whole time. Mm-hmm. Lazy my setup. So even like going down, I had to keep them out.
Yep.
Could I have torqued something?
That could totally be a piece of it. 100%. Yeah. I find that if you overdo a certain rotation, it can definitely flare something like this up if it was already an underlying thing.
One of the reasons why I hurt in the past was my K-box over here. I put it in the TV room and I was doing K-box squats all day watching TV. And that wasn't very smart. And like I said, the same day I was doing like this movement here.
Yep.
Dribble drills and stuff. And funny enough, like when I run, I was playing the other day, as long as I stayed hunched over and ran, like I just did like lunging and kind of minimized any sort of end range stuff.
Yep. And that's gonna change. Yeah, it's just gonna keep the knee in a much safer spot.
Since stretching a bunch, doing the mobs, I've gotten some like calf tightness.
Yep.
Maybe
totally normal. Totally normal. And I would say the fibular head mobilization that I sent you will also be a really good one. It just kind of replicates that internal rotation. But what you're going to want to do is space those TKEs throughout your basketball workouts. So, like every 15 minutes, hit a quick set of 10 of them.
Okay.
That
Um,
way we stay ahead of any aggravation.
is the swelling of concern? Should I just like go one day and then then try 2 1 days in a row before trying to go full Monty on this? Or
Yeah, so my thing for kind of the return to play is I have a stoplight analogy. You have red light, yellow light, green light. You can have a little bit of discomfort. If discomfort is gone within 30 minutes of completing the activity, that's a green light activity. You can keep going with that. If the pain and discomfort lasts with 30 minutes to an hour, then that's a yellow light. Activity is okay, but we probably need to tone it back. And then if it lasts more than an hour, then that's a red light and let's tone it back. So for you, because it's such a like quick, oh, it's here and then it's gone, it's more of the swelling that we're looking for. So at the end of a workout, if it swells up, if if it feels back to normal and the swelling's gone within 30 minutes, great, green light, you're totally good. 30 minutes to an hour, then it's like, okay, probably overdid it a little bit. And then if it's like, even if it doesn't swell up right away, if it's like hour or two later, it's swollen, it's like, all right, let's cut it back a little bit. So that's typically how I return people to play. So if you go out and you play and you're like, all right, we're going to do an hour, whatever, you're going to, have 15 minutes, like four different 15-minute sections. If you get to the end of that and there's no swelling, you're good to go the next day. If there is swelling, probably take a day off.
okay, so with the goal of playing 3 games in a day
Yep.
in the upcoming, not this weekend, but the following weekend, which gives us 9 days, would you advise me like progressively overloading it in the sense of we would with like a quad injury? Or would you rather say, hey, let's take a lot of days off, do some basic movements that don't really bother at all, like maybe a light jog,
Yes.
maybe, and then Monday kind of ramp or go back into playing. If
Yep.
it bothers some Monday, take Tuesday off and kind of like basically save yourself.
Yeah. So specifically with this one, we want to avoid things that aggravate it too much. So I would say if there is a movement that is going to aggravate it, like a deep squat, which you already don't do, then just don't do that until after the tournament. I would say your best bet is keep the ranges of motion small and keep it predictably non-painful. We want to minimize the number of variables, right? If we throw the kitchen sink at it, we don't know what's good and what's bad. If we keep it really, really simple, like V1 knee mobilization, like we have fibular head, we have extension, and then you have some foam rolling stuff. If we keep it ultra simple, then we know, all right, these things are either going to be, everything's going to work because they all go together, or, this isn't the right direction. Same thing goes with your lift. If you go complicated and complex movements with your lifting and you do a bunch of different things, you're not really sure what might trigger. But if you do like keep it really simple, single leg stability stuff, high box squats, something that, is really, really predictable that follows the same pattern, you can predictably say, all right, this is good, this is not good. But if there are too many variables, then, we don't know what's working and what's causing it to flare up.
Gotcha. And with the games coming up, like if I just literally do the kickback machine, I'm probably like, I don't need
perfect. So if you do that and you're like, all right, I'm going to focus on, if I flare it up, it's going to be trying things on court, not lifting. That's what I would probably advise you to do. We're like, hey, do things that are guaranteed to not aggravate it, minimum possible. And then make sure you get through the next 9 days with no flare ups from just lifting.
Oh shit. Okay, good. You're still there. Good. Oof,
Yeah.
I thought phone call randomly.
Does that all make sense?
Yeah, and one thing with that for your information too, like when it first happened, even later on, like end range, when I jumped, that knee, if I could jump off 2 feet, it didn't really bother me. I didn't really do anything approach wise because I was kind of afraid of rotation.
Mhm.
Even though I can shoot off the move and stuff, didn't bother it. It seemed like end range rapid extension initially bothered it. I haven't done it since.
Yep. That's because that breaks the progression of forces. So we went passive first, right? If we clear you with passive, it's doing well. It's, at the very least, it's not hurting you. Then we go to loaded active, but it's controlled. And then, but that rapid end range extension just skipped all of the progression. So we didn't kind of clear you to do all that. So even as at a dead sprint, you're not probably getting full extension of the knee when you're playing basketball. You're getting some, but it's not like you're running 100-meter dash where like you're getting that triple extension playing basketball.
So do you
except for jumping?
Yeah. Is that occurring mechanistically because whatever it is not rotating or locking out appropriately?
Yeah, just because it's mostly because it's irritated, and we need to do things that we need to basically just check off. You need to do push-ups before you can do the bench press, essentially. Okay. So we need to clear like, hey, all of this feels good, and then we can do that rapid full extension. So I would not do crazy amounts of max jumping, but the bouncing is probably okay.
The stuff that was weird was when I through Monday to Tuesday to Monday, I played pickup Saturday. Totally fine. I played it because it's less intense than my workouts because it's like one day pickup.
Yep.
And you brought around. And it's more variability versus the same repeated motion over and over again. So I thought that was smart. And then Monday, I worked out twice. Felt like totally fine. And then I worked out a little bit Tuesday morning, sat in a car, drove a whole bunch, tried playing pickup, and I went to hell in the handbasket after.
Yeah.
But Monday I was like full of pretty high intensity. So is there a possibility I could jump intensity assuming things?
Totally. Yeah. I would say like just with an abundance of caution, like slow play the jumping. But there's a very high probability you could go out there and jump full go right now and be totally fine. But it's like, do you really want to, if you could wait 3 days and you could do these exercises for the 3 days and progress through this, is it worth the risk of going out and doing it today? And for me, it's not worth that risk. But in 3 days, we go through this, we progress it, we start to add a band, and then we're like, all right, we're feeling good. Now we can add that in.
We'll aim for Monday, some level of
perfect.
And we'll do shoot tomorrow morning for jump shots and nothing else.
Awesome. That sounds good. I got to run here, but let's keep texting and talking on the phone and workshopping this stuff. But I like that standing loaded internal rotation TKE now for you.
So should I just put a band on it and do that same thing, like traditional TKE, but internally rotated?
Go no band for today, and then band tomorrow. If it feels good today, then band it tomorrow.
And sets and reps would be?
Go for 30 total.
Okay.
So you want to do 3 sets of 10 would be great to start. If that's okay, you can do another 3 sets of 10 later in the day too.
Okay, cool. If people want to follow you.
Yep. Dr. Michael Risher on Instagram. And then I don't even know what the Twitter and stuff is. I think it's Dr. Risher on Twitter, but.
Well, awesome. I appreciate you hopping on here and sharing all this with people so they can see it firsthand. Your knee course. Send me the link to your knee course so I can put it in the video. And
perfect.
It's probably tomorrow.
Awesome. Sweet, brother. Have a great rest of your day.
That's cool. I enjoyed it. All right.
Yeah, that was a lot of fun. All right. See you, Max.